Um, I know you all are eager to go out there and buy your Father's Day gifts. Um, so instead of going for a walk, we're going to run. My topic is PAD, and I just try to go through some slides. Make sure we get you out of here by 5 o'clock. Um, Patients with severe symptomatic PAD, guys, this is a massive problem. Most people, at least 25% people, don't even make it to 5 years once you have that. It is as having PAD, having kind of a lower ABI is as bad as what is called Framingham high risk category, which is you have a 20% mortality at 10 years. So it's really a bad thing to have. Smoking, diabetes, hypertension, dyslipidemia are the common risk factors. I'm going to focus on this slide a little bit more. So which are the patients I want you all to be on a watch out for? Age less than 50, well, all of you. With diabetes though, hopefully none of you, but with one additional risk factor, you got to be watching out for PAD, whether it's smoking, dyslipidemia, hypertension, or hyperhomocystinemia, okay? If you're age 50 to 69 and history of smoking or diabetes, you got to be watching out for PAD. Age 70 years and older, everybody. That's why CMS actually pays for a screening ABI. Anybody with leg symptoms with exertion, such as your claudication or ischemic rest pain, abnormal lower extremity pulse exam, or, and the most important, known atherosclerotic coronary, carotid, or renal artery disease. Once you have atherosclerosis, you most likely will have it in your legs as well. There are varieties of differential diagnosis. Let me skip through that. What are the clinical presentations of PAD? Asymptomatic, without obvious symptoms, complaint. Classic claudication, lower extremity symptoms confined to the muscles with a consistent and reproducible onset with exercise and relief with rest. Please remember those lines. Atypical leg pain, lower extremity discomfort that is exertional, but that does not consistently resolve with rest, consistently limit exercise at reproducible distance, or meet all the question or criteria which impacts your quality of life. Critical limb ischemia, or CLI, which is ischemic rest pain, non-healing wound, or gangrene, and acute limb ischemia, which are the 5 Ps, which Dr. Bavare talked about, which is pain, pulselessness, pallor, paresthesias, and paralysis. And there's polar, which is a 6P, which is cold. This is the heart attack of your leg. Okay, remember that. What are the clinical presentation of PAD? Again, we talked about 50%, the vast majority are asymptomatic, so they have blockages, they just don't feel it. The only 15% of the classic or typical claudication, the vast majority have atypical leg pains, and only 1 or 2% CLI, but which is a kind of almost an emergency or urgency in terms of limb salvage issues. Because once you develop CLI, it's really bad. About 45% people stay alive without amputation, but 20% are dead within the first 6 months, and about 35% are alive but with an amputation. This is an important slide because we get a lot of referrals for evaluation of PAD, but they turn out to have something else. The commonest reason is for elders, spinal canal stenosis, peripheral neuropathy, and so on and so forth are the other reasons. So how do you differentiate? Well, clinically, claudication versus pseudoclaudication. Because you'll see patients in your clinic, in your practice saying, my leg hurts. Well, first of all, claudication is cramping, tightness, aching, and fatigue. It usually happens in buttock, hip, thigh, calf, or foot. It's almost always exercise-induced. The distance is consistent. Occurs with standing? No. This is the biggest giveaway. Remember that, guys. If somebody says, doc, it hurts when I stand for long hours, it is not PAD. I mean, the patient may have PAD, you may fix it, it will not go away. Action of relief is standing, and time to relief is less than 5 minutes. This is a classification. I'm not going to ask you to memorize them, but it's important for you to remember that once it goes to level 2, we are getting into CLI category. So Rutherford class 2 and above are really bad. What are the differential diagnoses of foot ulcers? Again, if there's a normal pulse, it's usually neurological. If there's no pulse, obviously it's ischemic. Ischemic are also very painful. Neurological ulcers are usually painless. This is a classic example of critical limb ischemia where you are having ischemia of the toe and the foot. So what are the diagnostic testing? There are varieties of them. The first always should be ABI, and we'll go through the others as well. So how is ABI done? I'm going to spend a few minutes or a couple of minutes on doing ABIs. Everybody should know this. So number one step, Doppler ultrasound of the arterial blood flow in the brachial artery, Doppler ultrasound of the blood flow in the ankle arteries. ABI is basically nothing but lower extremity systolic pressure divided by the brachial artery systolic pressure. It is very sensitive and extremely specific to establish PAD diagnosis, and it obviously identifies patients who are at high risk of cardiovascular ischemic disease. I mean, you can actually use it in your practice as identifying people who are at high risk for anything cardiovascular at all levels. We went through all the indications on patients you should be doing this, but these are the numbers I want you all to remember. Normal is 1 to 1.29. 0.91 to 0.99, borderline, not sure. 0.41 to 0.9, mild to moderate, and less than 0.4 is obviously severe. Sometimes it can come up high, and those are called non-compressible vessels. So just to give you an example, you guys do all these pressures. Brachial systolic is 150 on the right, on the left is 160. Well, you're going to take the highest brachial. Then you're going to do posterior tibial, which is 40 on the right, and dorsalis pedis is 80 on the right. So you're going to take, for the right, 80 over 160, and your right ABI is 0.5. So you take the higher of the leg and higher of the arm on whichever side, and something similar on the left side. So remember how it is done. TBI or toe brachial indices are used sometimes where you have normal ABIs, but you're still concerned about circulation downstream or non-compressible vessels. Segmental pressures, I don't know if you've ever seen those, but you can literally put blood pressure curves top to bottom and see where it drops, and you kind of get a sense as to where the blockage is. So here, for example, this is mid-thigh. 150 becomes 100, and you know exactly where the blockage is. On the left leg, it is kind of around the popliteal or the knee area. 146 becomes 100. You can also look at waveforms or PVR, and you can see those are normal arterial waveforms, which is triphasic, and here it actually becomes, it loses its triphasic, becomes biphasic. Exercise PAD testing, it kind of confirms the diagnosis. Sometimes we unmask it, and it's good at utilizing claudication or pseudoclaudication. So first test, as you can imagine, is always an arterial Doppler to know where exactly the lesion is and to confirm the ABI reports. MRI has been used very commonly, and this is pictures about how good they look. So are CTAs. We have used a lot of CTAs, but it requires contrast, as you can imagine, along with radiation. And the treatments are, the number one is exercise training. Surprise. Actually, there is something in the 8 hours you'll learn here which can be treated by exercise. So this is something with the first therapy of option where you have to do 3 to 5 supervised sessions in a week, and duration is 35 to 50 minutes. Length is about for 6 months, and you actually have 100 to 150%. So in patients with PAD, recommend that they do daily walking exercise. If that doesn't work, then there is pentoxifylline, then there is silastazole or Platal, which is given as 100 milligrams twice a day. It's a platelet aggregation inhibitor. It also causes some of the other beneficial effects. However, when we studied silastazole or Platal versus pentoxifylline, which is also called Trental, guess what? Platal does so much better than Trental that I can't remember the last time I prescribed Trental. So everybody should get Platal if they have intermittent claudication. Now, this is also very important. So a lot of times people say, well, aren't you going to give my patient Plavix? He has PAD. Well, no. Plavix is only used to reduce ischemic events and for CLI, but not for claudication symptoms. If you really want to improve claudication symptoms, you use Platal. Okay? Let's skip through this slide. So for aortoid, I'm going to just go over where from the abdomen down all the way to the toes. Bottom line is, remember that the outcomes of whatever surgical intervention, endovascular, stent, surgery is better when you're higher up. The lower you go, the worse the outcomes. So high procedural success rates in the aortoiliac disease, excellent long-term patency, but as you can imagine, poor outcomes if you have very long occlusion, multiple stenosis, and poor runoff. For the femoral, excellent procedural success, very easy to do. Patency varies, but primary stenting also remains incompletely defined. So as I just pointed out, top to bottom, But again, these are the bypasses. If you have to go inside the abdomen, your surgical mortality is very high. The bottom line is the PAD coalition and PAD guidelines, public awareness of peripheral arterial disease, where individuals at risk or with PAD seek care from primary care, and the clinical awareness of PAD, which is where individual at risk with PAD receives vascular care. So thank you.